No, sir, we are good to go.
Good evening, doctors. This is Nitin from Pfizer. I welcome you on behalf of Pfizer to this expert panel discussion on treatment benefit of CDK4/6 inhibitors in hormone positive and HER2 negative advanced breast cancer in clinical trials and the real world. We have a very exciting panel today. The discussion would be led by Dr. Sandeep Goyale, who is the senior consultant medical oncologist at Kokila and Dhirubhai Ambani Hospital, Mumbai. And then we have Dr. Neeraj Bhatt, who is a senior consultant medical oncologist at Hemato-Oncology Clinic, Baroda. We have Dr. Jayan Gawande, who is a consultant medical oncologist at Aditya Birla Memorial Hospital, Pune. Dr. Jay Kumar Dadania, who is a senior consultant medical oncologist and hematologist at Sterling Hospital, Ahmedabad. And also we have Dr. Rajesh Patidar, who is a consultant medical oncologist at Churchram Hospital, Indore. So I now hand over the proceedings to Dr. Goyale to take this meeting forward.
Right. Thanks, Nitin. Thanks, Pfizer, for giving us this opportunity. We have already introduced the panelists, so we'll move on with the program today. I think the purpose of this meeting is to just get a feel of, let me just revise the data of palbociclib and other CDK4/6 inhibitors in advanced hormone receptor positive HER2 negative breast cancer. At the same time, have a look at the real world data, and also to share our clinical experience, I think, which is the most important. How do we utilize this data into our day-to-day practice, which is most important. And in between, I think let us keep it a bit informal. So if we have to have any questions in between, we can discuss a bit of a cases also. If you have some interesting case which you want to share and discuss, can also be done. So finally, just to gather some information and share information. So I'm just going to quickly go through the data of palbociclib and CDK4/6 inhibitors. We all know the data, but just to revise the benefit of CDK4/6 inhibitors in hormone receptor positive HER2 negative advanced breast cancer. So this is the disclaimer. It's only for medical healthcare professional purposes. We all know that all the guidelines now recommend CDK4/6 inhibitors as the standard of care in the first line and the second line therapy of hormone receptor positive HER2 negative advanced breast cancer patients. All the guidelines, NCCN, ESMO, ABC5, all of them, and the evidence shows that there's a very good improvement in the PFS, the response rates, and some improvement in the OS as well in some trials. And that is why this is the standard of care. Hardly any patients of advanced breast cancer hormone receptor positive would go without being treated with CDK4/6 inhibitors. These are the different trials. We've got 3 drugs and we've got 3 sets of trials. The Mona Lisa trials with ribociclib, Monarch trials with abemaciclib, and the Paloma. These are the first trial. The Paloma palbociclib trials were the first ones to show the benefit, and hence Palbo came much before the other 2 molecules. And you can see the hazard ratios in the PFS and the OS are sort of similar in all these trials, in all the first and second line settings with the different 3 medications. But saying that, I think the medicines, they act similar, but there are certain differences. And that is where the clinician has to have the knowledge as to which drug to use when. And that's what we're going to discuss, that are these all drugs similar, or which setting we have to use one or the other. These are the pharmacology of CDK4/6 inhibitors. Coming on to the data of Palbo, this is a Pfizer-sponsored meeting, so we have to discuss the data of palbociclib. This was a Paloma 2 trial. The first and Palbo plus letrozole versus letrozole alone in estrogen receptor positive human HER2 negative advanced breast cancer. This was the first CDK4/6 inhibitor, phase 3 study, and the median PFS at the end of 23 months follow-up was 24 months with Palbo plus letrozole versus 14 months with placebo plus letrozole, hazard ratio 0.58. OS data were not matured, and therefore the final OS analysis is what we're going to discuss now. This was the study criteria: Palbo 125 per day, 3 weeks on, 1 week off, letrozole plus versus letrozole alone. And this was the PFS data. We all know the data of PFS benefit. Hazard ratio is a good, a good hazard ratio benefit with Palbo plus letrozole in the first line setting. This was the overall survival, and the overall survival benefit, although numerically was there, but statistically significant, there was no overall survival benefit with palbo plus letrozole versus letrozole alone. And again, this point we will discuss in the next few slides as to how valid or how important that is. There was some information that because there was missing data between the two arms, therefore the data might be skewed, and therefore you may not have got overall survival benefit. Now, how significant that is, we don't know. This was a post hoc sensitivity analysis, and this excluded the patients where the survival data was not available. And when you did that, you found that the median overall survival benefit was there, some hazard ratio of 0.86, and numerical value benefit also was there in the median OS. So whether the survival data which was missing, how significant that is, we don't know. This was the combined OS analysis of Paloma 1 and Paloma 2 trials. And again, you see that numerically there is a benefit, although statistically significant is not that much, hazard ratio 0.93. This is the time to chemotherapy. And if you see the palbo plus letrozole definitely delayed the time to chemotherapy. 38 months as compared to 29 months for letrozole alone, hazard ratio 0.73. These were the common side effects, and these drugs are very well tolerated. We all have experienced that. Neutropenia is the commonest, but this is on paper neutropenia. We hardly see any neutropenic infections or any febrile neutropenia, and therefore these are well tolerated drugs, can be given. Fatigue can be an issue in some cases, but otherwise palbo is quite well tolerated. So in conclusion, Paloma 2 met its primary endpoint of improving PFS and other secondary endpoints. Response of 55% versus 44%. Safety profile was without any evidence of cumulative toxicity, and quality of life was maintained. Very important to know that quality of life was maintained. OS was numerically longer in the palbo plus letrozole arm, but the results were not statistically significant, whether it was because of more patients with DFI less than 12 months, or whether it was because of the data, survival data missing, we don't know. So that's why they said the interpretation of OS data was limited by the large and disproportionate percentage of patients with missing survival data between the treatment arms. These are the Paloma 3 in second line versus plus fulvestrant versus fulvestrant alone. And again, showed improvement in the PFS. Median OS was 34.8 months in the palbo arm versus 28 months. And that also 23% of 5-year overall survival rate as compared to 16%. They further classified into whether prior sensitivity to endocrine therapy or without sensitivity to endocrine therapy. And patients who had a prior sensitivity to endocrine therapy had a good improvement in median OS, almost about 10 months improvement as compared to fulvestrant alone. And patients who did not have a sensitivity to prior endocrine therapy did almost the same. This was the updated PFS results, 11.2 months versus 4.6 months. Again, a good separation of curves and good hazard ratio of 0.5. In pre and perimenopausal patients also, the second line setting did as well as the postmenopausal patients. These were the conclusions of Paloma 3, well tolerated, median PFS of 11.2 months versus 4.6 months, and effective treatment option for patients who have progressed on prior endocrine therapy. This is the data of some first-line trials in postmenopausal women. And I think the difference here, Paloma 2, Monarch, and Mona Lisa, is showing that in the Paloma studies, what we have found is that patients who had a disease-free interval of less than 12 months, there were more proportion of patients as compared to the other two trials, and whether these could be classified as a more aggressive disease. And, that could have impacted the overall survival. We don't know, but for sure, it had more number of patients who had aggressive disease interval less than 12 months. So now coming on to, this was the data of palbociclib. We also know the data of abemaciclib and ribociclib. So now we start with the panel. And I think that's where the most important part is, how does this data impact our day-to-day clinical practice? So let me start with Dr. Neeraj. Neeraj, what is your treatment of choice in hormone receptor positive, HER2 negative advanced breast cancer patients? Do you treat all of them upfront with CDK4/6 inhibitors, or do you start with a single agent AI or fulvestrant and then add? So what is your take on that?
Well, Sandeep bhai, my preference as of now is to start patients on aromatase inhibitors plus CDK4/6 inhibitors upfront, especially those who have bone only metastasis, less amount of visceral metastasis, and are less toxic. Even in patients who have high volume metastasis, my perception is CDK4/6 inhibitors plus AI based therapy works better compared to chemotherapy. So, of late, yes, my choice has always been to offer AI plus the CDK4/6 inhibitors based therapy. Preferably, most of my patients are on pelbociclib compared to ribo or abemaciclib.
Right. So, Neeraj, just taking this forward, which patient would you give chemotherapy then, or would you not give any patient chemotherapy?
If patient have high visceral metastasis like liver or lung metastasis are symptomatic for it, where I want immediate or early response, I would consider those patients to put on chemotherapy first.
Okay, so that's a very valid point where you want immediate response. So the next question which I would like to ask, let me ask Dr. Jay Kumar. Jay, do you think these drugs in combination have got a slow response, or do you think you have seen some faster responses as well?
So, sir, I have found some faster responses as well as compared to aromatase inhibitor alone. So, I think CDK4/6 with aromatase inhibitor should be the standard treatment option in those who do not have visceral crisis.
So
as compared to only
agree with Jay, because there are these drugs, the time to response is quite short. It's a good chance that they can. So even if patients have got extensive liver mets and bone mets and lung mets, you can still consider using these drugs if they're strong ER/PR positive. In these patients, you can still avoid giving chemotherapy. Rajesh, what is your take on this? Chemo
Yes, sir.
versus AI, CDK4/6 inhibitors.
I agree with the two panelists, sir. Usually, I give CDK4/6 inhibitor along with letrozole, unless patient is in a visceral crisis, real visceral crisis.
Right. Jen, can I ask you, in your last 10 patients you would have seen with advanced breast cancer hormone receptor HER2 negative, how many of you would have given chemo, or how many of you would have done AI alone, or how many of you would have given AI plus CDK4/6?
So chemotherapy, I would say 2 out of 10 may have received chemotherapy. So almost 8 patients are good to go on hormonal therapy. Now, whether mono or plus CDK4/6, finances was an issue up till now. So that was the reason where patients were put on single agent AI. Otherwise, all affording patients, I prefer a combination with CDK4/6.
Right. I think he's again got a point of finances, and which is a very valid point. But the last moment, what he said is all affordable patients he would put on CDK4. I think that's the key. All affordable patients, who can get should be given. Any patient, Neeraj, would you prefer to give just hormone therapy alone? And
yes, if patient is hemodynamically stable, cannot afford, well, the question of affordability has now been nullified. So given the standard case scenario, I would definitely prefer to put the patient on AI plus CDK4/6 inhibitor rather than offering only AI. I think it should be obsolete. Offering only AI in HR positive, HER2 negative cases, HR strong positive, I don't think that is going to be a standard practice anymore.
Anybody would differ or would all agree? Anybody can say this.
Maybe a patient who has got a very long DFI, more than 5 years, 10 years, maybe that may be a candidate for a single agent AI to begin with. But any patient with an advanced MBC hormone receptor positive has to receive a CDK4/6 somewhere in his natural history.
Well, in all the subgroups, in fact, in all the subgroups, progression-free survival is far better compared to AI alone.
Yes. So I think the data-wise, we should offer everybody. But I think always we find that in our practice, there might be 1 or 2 patients like elderly ladies who have got hormone receptor strong positive, low volume disease. in those patients, I still feel that we can still get away by just giving us. The reason for that is the monitoring is less. When you give single AIs alone, the monitoring is less. These patients may find difficult to come very regularly for blood tests. So that's why I think there are small subgroup of patients where I still feel we can still use only a single agent AI as we used to do earlier. There's patients where we don't want to have them repeated monitoring done, because with CDK4/6 inhibitors, any of these which you use, you have to have at least a blood count every month or something to check whether they are, what the neutrophil count, everything is. So,
yeah, another question, sir. I have one question for this in this scenario. It is said that especially for palbociclib and ribociclib, the 1 week period which is given off is the one where most of the WBC counts recovers. And it is said that even if WBC count does not recover, say it hovers around 2,500 or 3,000, one can still start a new cycle. So in this scenario, how important is it to frequently check CBCs? If patient usually responds well, or initial 2-3 cycles are going well without any major differences, without any major fall in WBC count.
Right. So there's a very valid point, because if you see most of these patients in the first 1 to 2 months or 2 to 3 months, you get a feel as to how they are tolerating the drugs. And I think we can definitely increase the duration of testing the CBC in these patients. The question is only when the counts are 900, 1,000, when they want to reduce the dose. I think that is where the first 2-3 months will tell us, how these patients are behaving. And then definitely you cannot monitor it once a month. But the patients themselves sometimes would like to monitor, and they say, because the counts can fall low. They're also worried when they see the counts low. And that is why it's reassuring for them also to check it regularly. But yes, can be increased, the duration can be increased. Even the other problem which I find is the 7-day period of break. Sometimes because of patient time, doctor time, can become 10 days, 11 days. Do you think in your practice this happens? Let me start with Neeraj. What do you think in your practice? Does it make a difference? 7-10 days or?
Sir, yes. You mean to say if that off period is stretched to more than 10 days instead of 7 days, will it make any difference in the outcome?
Sometimes the patient cannot come on that 8th day. Sometimes you are not there in the OPD, and sometimes, so that's what happens with me at least. So I don't know, is it happens with others? Neeraj, what is your experience?
Well, in my opinion, if that off period stretches to 10 days instead of 7 days, I don't think on long run it is going to make any major difference in the outcome. Exactly. If it is for only 1 or 2 cycles, rather than it being a regular delay.
Jay Kumar?
Yes, sir. I go with Dr. Neeraj Bhai. So if I think many of the patient they come after 10 days or beyond 10 days, and in that sense it doesn't, I think, change somewhat a prognosis in that particular part.
In fact, there have been instances where there is a significant thrombocytopenia, because of which I'll have to postpone treatment.
Right.
Because we can correct neutropenia, but we cannot correct thrombocytopenia, and even thrombocytopenias are not being corrected so easily. So sometimes instead of 7 days, I'll have to wait for 11, 12 days by giving romiplostim. So this also happens.
So the reason why I brought this point out is I find that even if you wait for 7 days or 10 days, it doesn't make a difference. The patient is still responding and the scan is still good. So the 21, we try to maintain the 21 7-day. Jayant, anything in your practice, are you able to maintain the 21 7-day period, or do you think it goes late?
Yes, sometimes it does go late, but as far as possible, at least in the initial 2-3 months, yes, I try to stick with the 21 and 7-day protocol. And later on, maybe 7-10 days doesn't make a difference.
Right. Now, coming on to the next question, which is, I think, is the most important question. You've got 3 CDK4/6 inhibitors. And how do you decide in your practice as to which CDK4/6 inhibitor use? Now, let's forget for one moment that we are in a Pfizer-sponsored meeting, and let's go with the academics. And what is your personal preference? How do you choose? Let me start with Rajesh. Rajesh, how do you choose? These CDK4/6 inhibitors.
Before choosing, I would look at the cost and side effects.
Right.
So in my opinion, pelbase and ribociclib both are well tolerated drug. So usually I choose one among these two.
Right. Uh, any any particular patient characteristic or disease wise you would choose one or the two, or how do you, like, anything side effect wise, what do you do?
Pelbase is very well tolerated drug, sir. So this as a side effect profile, it can be given to any patient.
Okay. Neeraj, your thoughts? But this
Well,
is the
sir,
most important. So I have to ask everybody this question. Yeah.
yeah, I have maximum experience with palbociclib.
Yeah.
The major side effect that I have come across is neutropenia, and that is non-febrile neutropenia. I would say most of the patients, even if their count falls to less than 1,000, even then they do not develop fever or infection. So my maximum experience is with palbociclib. Theoretically, ribociclib is known to cause cardiac arrhythmias. That may be a deal breaker. Abemaciclib has many GI side effects apart from cytopenias. So, but then since there are no cross-trial comparisons, we should consider all of them as equally efficacious. But personally, my maximum experience is with palbociclib.
Jay, any disease characteristic, like patients, for example, with liver metastasis, or would you prefer to use any of them, or would you prefer to use one over the other? Liver metastasis, because I think liver met not very easy to treat. So would you choose any of them?
I think there was some one of the observation in abemaciclib monarch study that patients with liver metastasis responded well to them, but I exactly am not aware, sir. But yes, regardless of type of metastasis, if the one CDK in 4/6 inhibitors I have to use, I'm more comfortable with pelbase. This is what I feel.
And
I think other
Jayant, your
panelists can
thoughts?
take this question.
Jayant, your thoughts?
Yeah. So with the abemaciclib, we have some data that it in patients with primary endocrine resistance, and it has also shown some CNS effect.
Yes,
So it
yes,
does cross the
yes.
CNS barrier. So
Yes.
these are a few points in favor of abema.
So I think, because we have been using these drugs more and more, we are now trying to identify a subset of patients where you would use palbociclib, where would you use abemaciclib, where would you use ribociclib. And there is some data of liver mets and brain mets where you can use abemaciclib over the others. Palbo, I find, is a wonderful drug, very safe, and I think most of the patients who are put on Palbo are still doing well after 2 years, 3 years. They're still doing well, without hardly any. The quality of life is very good, which may be suffering a bit with abemaciclib and ribociclib. Again, ribociclib with the hard QTC interval and all is a bit problematic. But overall, that is where I think a clinical experience comes into play to decide which one should be given in which patient. And so there'll be a subset of patients who will be for Palbo, there'll be a subset for Abema, for Ribo, like that. But most of them would be similar, but subset of patients will be there. Coming on to the next question, which parameter do you consider before selecting any? I think this we have discussed: safety, monitoring, quality of life. So which is the most important? Neeraj, what is the most important in this, quality of life, your monitoring, safety? Would you think all are equally important, or what do you think with these criteria?
As far as selection of patients or selection of CDK4/6 inhibitors is concerned, there are marginal differences between these medications. The major advantage I find with palbociclib is single day, single drug, or once a day dose and single drug. Even dose reduction parameters are standard. So if patient is otherwise fine, there are no cardiac issues, liver, and like rest of the findings are normal, my preference would be for pelbase. But otherwise, there are no contraindications for ribociclib. Ribociclib, there are 3 tablets are required. And for abemaciclib, 2 times per day dosing is required. So all these findings, if we compare, taking palbociclib is the patient compliance would be relatively better. And side effect profile wise, also I'm more comfortable with using palbociclib over other this one CDK4/6 inhibitors.
Jay, in your experience, you have most experience with Palbo, Ribo, or abemaciclib, or is it
Yeah, my 80% patients are on palbociclib.
palbociclib?
I have 1 or 2 patients on ribo and 1 or 2 patients on abemaciclib.
And you're quite happy with the monitoring and the quality of life and the safety with Palbo.
Yes, definitely.
Yeah, I think that's very reassuring, because the more you use, and if you are, it's less hassle for the doctor as well. If the drug is not giving any major issues. Rajesh, what is your experience? How many more commonly with Palbo or with Leptro or abemaciclib? This
Sir,
abemaciclib or Ribo?
90% patients are on Pelvis and 10% on ribocyclics. Hardly 2 to 3% on ribocyclic. No
And
abemaciclib.
and Jayant, your take?
Yes, sir, similar. Most of the patients are on palbociclib.
Right. So I think
Very few on whatever.
what I gather from all the panelists is they're very comfortable using Palbo, not just because of the safety thing and then the monitoring, but also because the efficacy. And I also feel that these patients do well in the long term. You know. So would you still prefer Palbo despite the non-significant OS? And how significant that is, the non-significant OS? So let me start with Neeraj again. How do you take that into consideration?
Sir, as far as overall survival is concerned, one of the catch that was mentioned in Paloma 3 study was missing survival data. So that could have been the reason that overall survival benefit has not been documented. But otherwise, in my clinical practice, of course, it is too small to comment compared to the data that we have. But I personally feel that I get good results with palbociclib, and it is far better than using aromatase inhibitors alone. So as far as survival data is concerned, I think everyone can have their own opinion. But then one of the catch or reason that have been given for not improving similar survival data between AI alone and palbociclib plus AI is missing survival data. Based things can.
The question was that suppose you get this data, if you look at the non-significant OS in Paloma 2, will that deter you from prescribing Palbo and say, no, I'll prescribe abemaciclib or ribociclib, or will you still?
Sir, there are no cross-trial comparison. There are no head-to-head data. So before that data are available, I would rate every CDK4/6 inhibitor equally efficacious.
Right. Okay. I think that's the message which we wanted to get across. Jay Kumar, what is your take on the non-significant OS? Will that make a difference in your prescription, or would you just ignore it and say that it's a good drug, helps, good PFS, good response rate, so I'll just prescribe?
So I think all the CDK4/6 inhibitor likely to be same in terms of OS, but due to some of the issues with the missing data as well as the crossover of the CDK4/6 inhibitor in those with AI only subset of that Paloma 2 trial, that is likely to be a confounding variable with non-significant OS data. Otherwise, in Mona Lisa and Monarch, in both of these trials, that showing the significant OS advantage as compared to AI alone. Although there are no cross-trial comparison between this CDK4/6, but I think all of them are same and equi-efficacious.
Now, the next thing, which is also, I don't know how important that is that the disease-free interval of more than 12 months or less than 12 months, endocrine sensitive or endocrine resistant. And I was talking to Ishan, when he called me to discuss about the meeting. So I just told him that, I don't know how important that is when we choose the medication, which medication to use. So let me ask with Rajesh. Rajesh, if a patient is DFI less than 12 months and more than 12 months, does it make a difference in decision making about the CDK4 inhibitors, or would you still use any or use Palbo? What is your take?
Sir, I am still using it will not impact my decision making, but what I feel that this patient will not be do better well compared to those patients whom DFI is more than 12 months.
Right. So, but you still go ahead and use a CDK4 and full second line AI, whatever.
Yes,
but,
sir.
So it will not make a difference. 9 months or 15 months not make a difference, isn't it?
Yes, sir. Yes, sir.
What will make a difference will be the disease burden and how the patient is clinically. Right. Jayant, what is your take on the less than 12, more than 12 months?
So less than 12 months becomes a secondary resistant disease. So anyway, the disease biology is not good, irrespective of whichever CDK4/6 you choose. So the choice of CDK4/6 doesn't matter, less than 12 or more than 12. It is the prognosis which is going to differ. But definitely, even in a secondary resistance, a CDK4/6 combination will do better than a single agent hormonal therapy. So it is always a recommendation to start a patient on a combination, irrespective of the DA5.
I think this slide shows that in the Paloma 2 study, the disease window less than 12 months patients were 22%, which were not in the other studies, and therefore there could be a possibility that more aggressive patients were in the Paloma 2 study, which could have not shown the OS benefit. In the other two trials, the endocrine sensitive population was more, and therefore that could be driving the OS benefit in the other trials. So that could be one of the reasons as well, with the OS benefit or not OS benefit. I think treatment of choice, and I think we've discussed all this, about the resistant population. We all would go at the CDK4/6 inhibitors, and that will not make any difference to us in choosing. Coming on to again this. Now this was the ESMO breast cancer 2022 some data, the P-Reality X study about the palbociclib real world first line comparative effectiveness study extended, and this was where they had in the real world clinical practice in the United States, they got this data collected, Palbo AI versus AI alone. Almost about 3,000 patients, this data was collected. And I'm just going to show you this was the PFS data, again, hazard ratio of 0.68, 0.7, 0.72. And these were the conclusions that we all know Palbo plus AI more effective than AI alone in a heterogeneous population of patients with hormone receptor positive HER2 negative metastatic breast cancer and different patient subgroups. So that is what, again, in real world data also, this showed good efficacy. Now, this was some data about the Indian experience with palbociclib. There are a few studies which have been published. This was from Dr. Doval's team. From RGCI and BLK hospitals, Delhi, retrospective data collection of 188 patients, Palbo plus aromatase inhibitors or Palbo fulvestrant versus single agent. And they found that the median PF in the first line was 20 months, in the second line was 12 months, overall response 80%, and the second line is 48%. There were some complete responses as well. Toxicity in 10% patient grade 3 for adverse events. Again, no patient had febrile neutropenia. All had neutropenia on paper. That's what I said, paper neutropenia actually. So this was similar to the data seen in the Western population. This was the data from Amit Rauthan and team, Palbo in hormone sensitive Indian experience. Again, median PFS not reached in this study. Median PFS, the second line was 14 months. And again, in the bone only versus visceral meta, similar, I think, data they have got 14 months versus 13 months. This is from Chennai. Again, median PFS 18 months, median OS not reached, 1 year PFS 73, 1 year OS 89%. So all this data, we've got a lot of, from Jaipur as well, we've got some data. And again, median PFS 18 months as compared to in the first line and 13.8 months second line. This was some practical concerns recommendations regarding the use of hormonal therapy in metastatic breast cancer. Again, first line, we do AI plus Palbo, and second line fulvestrant plus Palbo or CDK6 inhibitors. So this was, the data which we discussed, and this is a summary. Now, the one question which I wanted to ask you guys is, which I find a problem in clinical practice, is that after some time, even the company gives them free medicine after 10 months or something, but the patients do get tired of doing these blood tests and all, maybe 2 years down the line, 3 years down the line. So do they come and tell you that, okay, can we just stop the monitoring? Can we stop the CDK4 inhibitors and continue? Because this happened to me in my clinical practice. So Neeraj, what do you think? Would you stop anybody on Palbo after 1 or 2 years if they're doing well and the disease burden less, and just continue AI alone?
Sir, there are no such data that stopping palbociclib
Yes.
will maintain the response that has been achieved by using dual therapy.
Yes.
So I would always advise patient to continue ongoing treatment as stopgap arrangement. If some patients are maintaining well, and we will be able to come to know about the trend of particular patients' WBC counts once we will follow them for 6-8 months. So based on that, sometimes I make it once in alternate cycles or once in 2 cycles, like that. I adjust the CBC investigations, but given the choice, I would prefer to do CBC once a month during every cycle.
So I think
So this is
that's what the problem is, Neeraj. Once a month or once in 6 weeks when you do a CBC, after some time, a couple of years, the patients do get really tired of getting a blood test done so frequently. And when you give AI alone, you call them after 3 months. So they are okay with that. So that was why, because a couple of patients recently have told me they've been on Palbo for last 2.5 years, and now they are fed up of doing blood investigations, once in 6 weeks or once in 4 weeks. So that's what I was coming from. Jay Kumar, what would you think? Would you stop anybody on Palbo if they come and tell you, or would you just tell them continue?
No, sir, I would not recommend to stop once there is a benefit of CDK4/6. I would recommend them to continue with the same. But I would recommend sometimes in this exhausted patient, I recommend them to do CBC every 2 monthly or in that sense, every alternate cycle.
Right. Rajesh?
Sir, many a time I work in tier 2 city, patient does not come. So patient even after calling they don't come, and I have seen that there is no much side effect. Patient do CBC at 3 months and they come, they WhatsApp. So it is not, I think after 6 months, it's not very hard and fast that we have to do investigation each and every month.
Okay, I think those by default the patient doesn't come only, so they don't do. So you are okay with that, but yeah. So does that mean that we can then tell them to do once in 3 months also?
Yeah,
no, sir. Legally, it is not acceptable.
Yes.
So if
I think
something goes wrong, we
that's
will
the
be
catch.
sued.
That's the catch. I think that's the catch. If they don't come on their own, we are
Yes, sir.
quite safe that they have not come on their own. But for us to tell them to come out of 3 months, if the counts have fallen really low, then I think we may be in a bit of a trouble. Right. Jayant, your take on how long to continue, or would you just continue as long as possible?
So agreed with everybody. It has to be continued till progression. We don't have any data to stop. So I would like to
Jayant, I think we've lost you. We can't hear you.
monitoring, yes, sometimes every 2 months CBC can be done if the patient is doing. Hello.
Yeah.
Just let me put my video.
Yeah.
Can you hear me now?
Now better.
So there is no data for no stopping. So I would like to continue till progression. And the question of monitoring, if the patient has been doing well for a long period of time, maybe every 2 months doing a CBC, you can go get away with it.
Right. So I think this, from my side, this was the presentation, the data, the real world data, and the questions which I had thought were important from practical point of view. This is the conclusion summary data. We all know that we have to use in the first. I think hardly any patients now I've been putting on chemotherapy upfront for metastatic breast cancer, advanced breast cancer, hormone receptor positive, HER2 negative. If they are ERPR strong positive, just go on for CDK4 plus, hormone therapy. Any questions from anybody? If anyone would like to share a case or discuss anything, please feel free, because we have got, I think, 10 minutes more. So anybody would like to share their experience, that will be helpful.
So I would like to discuss a scenario. Say you have a patient with metastatic breast cancer, started on CDK4/6 and an AI. The patient has done well for 2 years, and there is a single site of disease progression. Then what are you going to do? Say a single bone met.
Where? That's important.
A single
No, single site of disease progression where? Liver, bone?
Bone.
In the bone?
Yes, a single site of new bone lesion after 2 years.
and the patient otherwise quite well. There's no
Otherwise
tolerating
quite
well.
well,
There's no
yes.
disease. Well, I think it's in that
No.
case, I would just treat the local site, treat the solitary progression site locally, either by radiation or by surgery, whatever, and then continue the same. I would not change.
Yes, yes. Yeah.
I would not
So
change
that's
at all, because you can reserve for a progression later date, and you just treat locally, either radiation or surgery, wherever the site is.
right, right.
Anybody else, Neeraj,
Well,
Jay, anybody has a difference of opinion, or would you like to add anything?
Many
Well, I
times,
had similar experience. One of my patient has been on fulvestrant plus pelvis-based therapy for almost 18 months, and she had developed two new bone lesions while on treatment. But she is completely asymptomatic for those lesions, and the SUV of bone lesions are relatively low. So, considering the limitations of PET CT and the fact that patient is asymptomatic, I have continued her on same treatment and would evaluate her after 3 to 6 months again. So asymptomatic metastasis or new lesions is something we have to judge clinically and take a judicious decision.
Yes, yes. No, I think that's where your clinical acumen comes into play, because if you stop the medicine when it's working somewhere else, then what other options you have? Not many, because you already use AI, you've already used fulvestrant now. So then, and the quality of life also makes a big difference, isn't it? Any other case? Anybody has used Palbo in patients with serious metastasis in leptomeningeal disease?
yes, sir. I have used. One of my patient came on stretcher. She was having bulbar palsy,
Okay,
and I was thinking that she might not survive even.
right.
Then we plant palliative RT and started through Riles tube. We gave pelbocycline and letrozole,
Okay.
and she's still on the treatment for last 8 months. She's walking and she's perfect. All bulbar palsy has also recovered.
And how fast was the response?
It was very fast, sir, within 1 month. So now I feel, whether should we change the definition of Israel crisis in presence of
Yes, yes.
CDK4
That's what I was trying to hint in my first when I started this, that it's not a very long duration of long time to response. It's a very short time to response.
Yes, sir.
So that is why my chemotherapy for these patients is very, very less. I hardly use chemotherapy now because even for liver metastasis, for brain metastasis, I do CDK4 plus. That's what I was trying to hint, that it's very short time to response. These drugs are quite good.
And those patients are very thankful. She was on a stretcher. They were all expecting death, and suddenly now she's good.
Anybody has an experience with leptomeningeal disease metastasis or brain mets with CDK4 inhibitors?
Yes, sir. I do have that patient, elderly lady, 80-year-old, presented with the brain metastasis, and she's hormone positive, HER2 negative. And then after palliative RT to the brain, I have started Palbo with letrozole. Although with the lower doses of palbociclib, she is tolerating well, and she is now symptom free. And she's ongoing with almost 8 to 9 months. So
right. And and again, I'm coming to how fast was the response? Means was it in the
she
first scan
responded
after
within
3 months?
1.5 to 2 months.
1.5 to 2 months. Clinical response was there.
Yes, yes,
you
yes.
Then a scan of 3 months, but clinical response you started getting soon, right?
Yes, sir.
Yeah, so I think that's a very important point which I wanted to drive through, is that again, so that's why we have to make sure that we just don't put them on chemotherapy just because they've got liver metastasis or brain metastasis. These drugs are quite good. I think they have changed the paradigm shift in the treatment of these patients because of these CDK4/6 inhibitors. I think that's what. Anybody else would like to share any thoughts, any questions on the usage of these drugs, or right? So I think we're almost reaching 8 o'clock. So this is the final slide. We have shown that there are 3 CDK4/6 inhibitors, and now they've become the standard of care in using in hormone receptor positive advanced breast cancer HER2 negative patients in a combination with hormone therapy in the first and or second line setting. Similar drugs, similar efficacy, similar hazard ratios, slight differences in their mechanism of action, also in the neutropenia, the side effect profile, and maybe in the usage, like in liver meds, brain meds, and all. But that is where our clinical acumen comes into play, and to choose which drug to choose in which patient. The cost is a concern, with all these, and I think that is where, if we can reduce the cost. I think now we've got the generic palbos coming in. There are a lot of companies who are making generic palbo, and the cost is really economical. So I think that will also increase our usage of using CDK4 inhibitors. And I don't think so any patient would be going without the CDK4 inhibitors now, because the generics have come. So that's also a plus point. We have got a lot of data in the usage of these drugs, and that's why they become the standard of care in this subset of patients. Very well tolerable. Quality of life is also maintained. So I think it's a win-win situation for these patients and doctors as well who are treating these patients. So if there are no more questions or any thoughts, then I would hand over back to the organizers. Thank you very much for the session.
Thank you, sir. Rukaya, can you check if we have any questions on the chat box?
Yes, sir. Let me check. No, sir, there are no questions.
So there are no questions, sir. So with your permission, I would like to explain the new PAP that we have launched for Palbase, sir. So post the patent expiration, so we have changed our patient assistance program. Now with one cycle purchase for the first month, the next 3 months, the patient will get the PAP as assistance, sir, every month. So patient will have to buy only 1 month therapy, and the next 3 months would come as a assistance to the patient. And then the 5th cycle the patient had to purchase, and the next 3 cycles will come free to the patient, sir. So with this, the average cost of therapy for Palbase, the original molecule, would be close to 19,000 rupees per month, sir. Average cost of therapy.
And what about the free sample? After some time you give free, isn't it, for life?
Sir, so earlier, before this, we had the 9+ lifetime program. So the patients who are on that program will continue to be on that program. And from 10th of onwards, there is no lifetime support for Palbase now, sir.
Okay, 1+3, 1+3, 1+3 going
on. Yeah, 1+3, 1+3, that will continue, sir.
So that means about 19,000 rupees or 20,000 rupees per month they have to shell out as long as they are on the treatment.
Yeah.
So have you calculated, is this better or the previous one was better? Have you calculated for the patient, like, this way?
Sir, it would almost work out to the same, sir. Because the per year cost would be close to 2,40,000, and the 9 cycle cost was 6 lakhs rupees earlier. So in 3 years, it would be close to 6 lakhs rupees, sir.
So now the last question which I would like to ask the panelists is, with this PAP program, Jay, Neeraj, Jayant, and Rajesh, do you think your usage of original Palbo Sislim will change now with the generic coming in and with this PAP program, or would you think you would still prescribe, convince the patient that we have to pay 20,000 rupees per month? Jay, let me start with you.
I think in those who are affordable patient, we can continue with that innovator product. But in those who cannot afford that cost, then we can continue with the generic one. So I think many of the patients who cannot afford palbociclib previously, now they can afford when the generic is available.
Neeraj?
Yes, I agree that those who can afford or want to go for original brand, Palbase will always remain their first choice. And those who cannot, maybe 90% would shift to generics, maybe 95%, not more. So those who can afford, Palbase should be the way to go. And if they can't afford generics, there are many generics to choose from.
I think their thing is 19,000 per month. So Jayant, what is your take on this?
So agreed, sir. Patients who can afford will always prefer the original molecule. So as such, I don't think it will make a difference. Now also only the affording patients who are taking Palbase. So only the patients who could not afford, now the more number of patients will be on generic. Affordable patients, the number will remain the same.
But then there's no point of this. Then is no point of this PAP program, no? If it's not going to change.
No, in that case, sir, the affordable patient would have
think-
also taken generics.
Sorry?
In that case, affordable patient would also have taken generics. It is costly.
No, the reason why I'm asking is that, if the PAP program, they've got a new PAP program.
Yes, agreed.
In fact, my take is if Pfizer wants to stay in the competition, they still need to come out with even more competitive offerings.
Yeah, so I think the Pfizer guys are listening, aren't they?
Yes, sir.
Yeah, because see, that's something. If everybody, all the panelists are saying that the usage is not going to increase with this new PAP program, then I think you may have to think about how to adjust the PAP program. I mean, I don't know how much is the generic. Does anybody know how much a generic costs?
Sir, it costs from 3,500 rupees to 10,000
per month.
per month.
So this is almost double, isn't it?
Mm.
Yeah. So I think this is a feedback which the Pfizer guys can take and see if they can, make it a bit more competitive.
We take your feedback, sir.
Yeah.
And I'll definitely pass on to my superiors, sir.
Right.
So I would like to give a small vote of thanks. Thank you, Dr. Goyle, for a very beautiful moderation involving all the panelists evenly and getting the discussion on board. So thanks, Dr. Dadania. Thanks, Dr. Rajesh Patidar. Thanks, Dr. Neeraj Bhatt. And thanks, Dr. Gawande, for your time. And I also thank doctors who joined this link via a separate link to attend the meeting. We had close to 25 doctors who attended the meeting, sir. I thank everyone who took their time out today evening to be with us. We can now close the meeting, sir.
Thank you very much. Have a nice
Thank you, sir.
evening. Bye.
Thank you all. Bye.